Hypertension, or chronic high blood pressure, increases the risks of serious conditions such as stroke, heart attack, and heart or kidney failure. High blood pressure is basically defined by abnormal numbers. The systolic pressure is the maximum pressure in the arteries when the heart is ejecting blood. The diastolic pressure is the minimum pressure when the heart is filling with blood between heartbeats. This patient's blood pressure is about 165 over 70 millimeters of mercury. A person with blood pressure persistently more than 140 over 90 may be considered to be hypertensive. The medical risks, and therefore the need for treatment, depend not only on the blood pressure itself, but also on factors such as age, gender, ethnicity, and comorbidities such as coronary artery disease, diabetes, or obesity. According to Cannon's concept of homeostasis, the body's many variables, such as blood pressure, are not allowed to vary by much or for long. This is because of negative feedback regulation. In a negative feedback loop, there are an odd number of negative relationships in the loop. In this simple loop, there is one negative relationship. Think of the thermostat in your house. The thermostat compares the information coming in about room temperature with the setting determined by a controller, namely you. When the room temperature decreases sufficiently and for long enough, the thermostat senses the discrepancy between what the room temperature is and what the thermostat setting is. The furnace is then instructed to turn on, and the room temperature increases toward the set value. There's a theory that the brain has many comparators that act like thermostats. Taken together, they're called homeostats. And according to this theory, a barostat in the lower brainstem compares information that comes in from baroreceptors about blood pressure with settings determined by higher centers in the brain. And when the discrepancy between what is sensed and what is said is detected, traffic in the sympathetic noradrenergic system decreases. Because of the decreased sympathetic nerve traffic, the rate of release of norepinephrine, the sympathetic neurotransmitter, decreases. Then there is less binding of the norepinephrine to alpha adrenoceptors in the walls of blood vessels. The blood vessels relax and the blood pressure falls. The body has several effectors besides the sympathetic noradrenergic system for regulating blood pressure by negative feedback. You probably recognize two other components of the autonomic nervous system here. The parasympathetic nervous system via the vagus nerve, which is the 10th cranial nerve, and the sympathetic adrenergic system, for which adrenaline is the hormonal chemical messenger. Other effectors include the renin-angiotensin-aldosterone system and the arginine-vasopressin system. Because of the importance of the renin-angiotensin-aldosterone system in blood pressure regulation and in hypertension management, we have to describe this system in more detail. The kidneys filter the blood by millions of leaky blood vessels coiled into tiny ball-like tufts called glomeruli. Blood cells themselves normally cannot pass through the holes in the glomeruli, but the watery part of the blood, containing sodium, does pass through. The filtered fluid, or filtrate, then enters tiny tubes, tubules. Cells lining the tubules take up the filtered sodium and put it back into the bloodstream. The sodium that escapes this recycling stays in the filtrate and eventually leaves the body in the excreted urine. Specialized tubule cells, called the macula densa, or dense spot, monitor the concentration of sodium in the filtrate that has passed through the glomeruli. When the amount of sodium falls below a certain level, the macula densa cells send a message to other nearby cells, called juxtaglomerular cells, located in the walls of blood vessels heading toward the glomeruli. The juxtaglomerular cells release into the bloodstream the first effector chemical of the renin-angiotensin-aldosterone system, renin. The same juxtaglomerular cells also act as sensors themselves. They detect stretch, and therefore the distending pressure in the blood vessels. A fall in the distending pressure also leads to release of renin. Therefore, not just one but two homeostats in the kidneys regulate renin release. The main monitored variables in the kidneys for regulation of renin release are the pressure in the blood vessels approaching the glomeruli and the concentration of sodium in the glomerular filtrate. Stretch receptors in two places outside the kidneys contribute to renin release. Low-pressure baroreceptors are located in the walls of the chambers and veins at the entry to the heart. High-pressure baroreceptors are located in major arteries, especially in the carotid sinus, where the common carotid artery splits into the external and internal carotid arteries. When the amount of blood filling the heart falls, such as by a fall in blood volume, or when the blood pressure in the carotid arteries falls, such as from relaxation of blood vessels, then the brain acts on this information to direct an increase in renin release. Conceptually, the homeostat that regulates renin release to maintain blood volume as monitored by the low-pressure baroreceptors can be called the voluostat, and the homeostat that regulates renin release to maintain blood pressure as monitored by the high-pressure baroreceptors can be called the barostat. Renin has no known activity of its own, but it does act as an enzyme to speed up the conversion of a protein, angiotensinogen, to a peptide called angiotensin 1. Angiotensin 1 also has no known physiological action, but another enzyme, angiotensin converting enzyme, or ACE, speeds up the conversion of angiotensin 1 to angiotensin 2. And angiotensin 2 is one of the most potent chemicals of the body that constrict blood vessels. Angiotensin 2 therefore increases the blood pressure. Predictably, both ACE inhibitors and angiotensin 2 receptor blockers are effective and widely used to treat hypertension. Another key effect of angiotensin 2, which establishes the renin-angiotensin system as the body's main system regulating sodium balance, is to stimulate the adrenal cortex to release aldosterone. Aldosterone increases reabsorption of sodium from the tubules in the kidneys. Activation of the renin-angiotensin-aldosterone system therefore increases the blood pressure by constricting blood vessels via the vasoconstrictor effect of angiotensin 2, and also increases the blood volume and cardiac filling via the sodium retention produced by aldosterone. The renin-angiotensin-aldosterone system therefore is a key effector for two homeostatic systems, the barostat and the voluostat. Components of the autonomic and renin-angiotensin-aldosterone systems interact in several ways. First, stimulation of the sympathetic noradrenergic system increases renin secretion. Second, angiotensin 2 acts in the brain to increase sympathetic nervous outflows. Third, there are abundant angiotensin 2 receptors in the adrenal medulla. Angiotensin 2 can evoke release of adrenaline directly, and adrenaline increases renin secretion. Fourth, dopamine, which is the chemical precursor of norepinephrine and adrenaline, inhibits aldosterone secretion from the adrenal cortex in response to angiotensin 2. Blood pressure is determined by two variables. The cardiac output is the amount of blood ejected by the heart in 1 minute. This corresponds to the total blood flow in the circulation. The total peripheral resistance is the amount of resistance to blood flow in the circulation as a whole. To get a grasp of cardiac output and total peripheral resistance, think of the pressure in a garden hose. Turning on the faucet increases both the flow of water and the pressure in the hose. If you turn down the faucet, this would decrease the pressure and the flow. You could bring the pressure back up by tightening the nozzle, but the flow would decrease further. If the nozzle remained tightened, turning the faucet up would increase the flow, but now the pressure in the hose would be high. In most people with chronic hypertension, the cardiac output is normal or even decreased. This means that in hypertension, the high blood pressure is usually from high total peripheral resistance. The vascular nozzle is too tight. Just as two variables determine blood pressure, two variables determine cardiac output. These are the heart rate and the stroke volume. The heart rate is the number of beats per minute, and the stroke volume is the amount of blood ejected by the heart in one heartbeat. This presentation has emphasized that blood pressure is regulated by negative feedback. Input to the brain from arterial baroreceptors causes reflexive changes in activities of effectors, and this tends to buffer the effects of a perturbation of blood pressure. The sympathetic noradrenergic and the renin-angiotensin-aldosterone systems are two of the most important effectors in blood pressure regulation. The vagus nerve, the 10th cranial nerve, contributes to pressure regulation, especially by modulating heart rate. The sympathetic adrenergic system plays a major role in the high blood pressure commonly found in emergency situations. In addition to the barostat, a voluostat regulates blood volume and thereby cardiac filling and cardiac output based on information from low pressure baroreceptors. Although this diagram seems very complex, what is depicted actually is a relatively simple model compared to models hypertension researchers have developed. In this presentation, you've learned that the blood pressure is regulated by several effectors. The effectors include components of the autonomic nervous system. According to one theory, the effectors are part of negative feedback loops that maintain homeostasis by way of comparator homeostats. One may ask, if the body has available so many effectors to control blood pressure, why does hypertension even exist? What goes wrong with the negative feedback regulation such that the blood pressure becomes persistently high? Somehow, the complex interplay of the blood vessels, heart, kidneys, and the central nervous system goes awry. No one knows exactly what goes wrong, how, or why. A guess, and it's only a guess, is that the effectors that regulate blood pressure evolved to maintain homeostasis of other monitored variables and not blood pressure per se. Throughout human evolution, systems evolved to counter infection, to endure emergencies, to maintain the core temperature of the body, to distribute blood flows to body organs appropriately in different circumstances, to convert ingested food to energy and get rid of waste, to have correct levels of several electrolytes such as sodium, and to conserve water. These all have offered clear survival advantages. The side effect of increased blood pressure may have had relatively little significance. In modern society, these needs no longer are pressing, but the homeostatic systems may still be set in a manner that biases toward high intake of fat, sugar, salt, and water, with attendant increased blood pressure. Hypertension might then be a consequence of modern civilization.